the easy topic. Everyone is good with it. That is hypertension. Now, hypertension, there are two: urgency, emergency, blah, blah, blah. Both of these very severe things. Blood pressure more than 180, 120, that's urgency. Emergency means end organ damage, retinal occlusion, retinal damage, blah, blah, blah. Nobody's going to ask you all that. Just giving you a brief idea. More than 180, 120, it's urgency, emergencies, end organ damage. But if a patient is coming to you for the first time, has hypertension, what is the next step?
Check for other diseases like diabetes, etc.
Okay, very good. So if a new hypertension patient comes to you, you have to do some things. So number one thing you said diabetes, very good. You have to check for sugar, high yield. Then what other test?
Renal function test.
Very good. Renal function test, CKD test. So create, urine analysis, albumin, creatinine, electrolyte, all that. Then
Lipid profile.
very good. High yield lipid profile. There are questions on diabetes and lipid profile. Create is also high yield. Then
we'll do ECG.
very good. ECG. Okay. Superb. Then baseline ECG would like to do. Then one more thing you guys are missing. Just one more.
CBC.
No, something for hypertension. Like you do CBC blood count and everything is CBC CMP. I'm counting in. Other than that, something specific for new hypertension. TSH. Okay.
Okay.
So mug it up: diabetes, lipid profile, TSH, a renal function test, and ECG is high yield for new hypertension. Questions on this, lot of. Got it?
Okay.
Okay. Now this whole test is done. Everything comes normal. But the blood pressure is still high. The first visit they are here. Then what next?
So it's hypertension. We'll start the therapy, the medication.
Wrong.
We will check it one more time after 2
Okay.
weeks.
After?
Ambulatory blood pressure.
But what did you say? After 2 weeks?
Yes.
Yes, so that is right. You never start any medication the first time the patient has hypertension. You don't go for ambulatory at this time. You repeat the blood pressure after some time, that is 1 or 2 weeks. Call them again, check the blood pressure. If it is still high, still you don't try it. The third time you bring them in, and if the blood pressure is still high, at that time you start the medication. Okay. So you have to check 2 to 3 times. If it is high at 2 to 3 office visits, then you can think of medications. Clear?
Yes.
Okay. Then what are the medication? What is the initial treatment that can be given for hypertension? First line.
AC inhibitors.
Very good. ACE inhibitors.
Diuretics.
Diuretics. Okay. Thiazide diuretics. ACE inhibitors. ACE and ARBs are like best friends. They go hand in hand. So ACE inhibitors, ARBs, thiazide diuretics, and one more.
Calcium channel blocker.
Very good. Calcium channel blockers. Now just mug up these four categories. Okay. Because then there are questions where they would say that this is right, this is right, this is right. Nothing is helping. What else to give? And you have CCBs, beta blockers, something more tempting at that point. So just remember, you have to pick something from these four only. Always. ACE inhibitor, ARBs, thiazide, CCBs. Clear?
Yes.
Only these four.
Oh.
Then there is this thing called, if the patient comes to you and the blood pressure is 180 over 70. What is this?
Isolated systolic hypertension.
Very good. Isolated systolic hypertension. What is the cause?
Seen in elderly.
Very good. Elderly. Mechanism of action.
Increase the stiffness of the.
Very good. Very good. So that is important.
Yes.
Increased stiffness or like decreased compliance of the aortic or the arterial valve that is causing increased systolic blood pressure only. Clear?
Okay.
And the treatment for this one is going to be monotherapy with any of these thiazide, CCBs, ARBs. But monotherapy, single one is going to work. Clear?
Yes.
Okay. What if a patient comes to me and says that the patient is taking OC pills and this is a new patient, a 30-year-old female coming with hypertension? What would I recommend?
Discontinue OCPs.
So there are two options: continue OC pills and give antihypertensive because she does not want to get pregnant, and other would be discontinue and prescribe alternate form of contraception.
I think alternate form of contraception.
Yes. Yes.
Everybody, yeah, yes.
Mm-mm.
So the answer is discontinue and prescribe the alternate form of contraception. All right. Don't start antihypertensives because this is because the reason is OC pills. So if you treat the underlying cause, the hypertension is going to go away. All right.
Okay.
That is also one concept. Then about the treatment of hypertension, other than medication, any other recommendations that you do?
Weight loss,
We use a special diet for hypertension.
exercise.
Dash diet, very good.
Smoking,
Exercise.
weight
Okay,
loss.
exercise, sodium, all those are there now. But I want you guys to focus on these two: weight loss and dash diet. Remember this, always remember this. Don't make a silly mistake. If a patient has higher BMI, then for them, the first line is weight loss. But if a patient is with normal BMI, then for them, the first line is dash diet.
Mm-mm-mm.
Okay. So again, both will be given in the option. Check the BMI of the patient. If that patient has a normal BMI, then weight loss is not the answer. Answer is first a dash diet. Then of course exercise and everything is going to come. Weight loss is going to come. But normal BMI, then dash diet. Higher BMI, then first line is weight loss. Second line is dash diet. Got it?
Yes.
Yes.
Perfect. Don't do that mistake. Okay. Pregnancy. Do you know about any antihypertensives that can be given in pregnancy?
Uh,
Magnesium sulfate.
no, like
Okay,
lapital.
magnesium sulfate is there, but that is for preeclampsia or eclampsia.
Calcium channel blockers, hydralazine.
So there was a mnemonic. There are actually a lot of mnemonics for just these four drugs. I just know one that is he loves my neonates. Neonate, sorry. He loves my neonate. Hydralazine, labetalol, methyl dopa, and nifedipine.
Yes.
Okay, mug it up. Hydralazine, labetalol, methyl dopa, and nifedipine. The trick part is sometimes sometimes only if they want to get complicated with you. Hydralazine causes a tachycardia, so you cannot give in mothers who have a baseline tachycardia. Labetalol has side effect of bradycardia, so those whose heart rate is already low do not give labetalol. Methyl dopa is not given in preeclampsia. It is only for patients who have like chronic hypertension, not hypertension of pregnancy, but chronic hypertension. For them, you can give methyl dopa. New onset hypertension after 20 weeks means preeclampsia. You don't give methyl dopa.
Mm.
And nifedipine is best. So yeah, no other side effect. So why I'm mentioning this? Always safe to give nifedipine. There was a question where labetalol and nifedipine both were there in the option, and that I just got super confused. I did not know at that time. The patient had bradycardia baseline, so labetalol was not given, and the
Mm.
answer turned out to be nifedipine. So from that one, just one MCQ. So it's not necessary that you will get it, but we should remember one side effect might help. Okay.
Oh,
Hydralazine tachycardia, labetalol bradycardia, methyl dopa only for chronic hypertension, not for preeclampsia. Nifedipine for anything. Got it?
Okay.
Okay. Talking about hypertension in pregnancy. So, like, there's one thing is chronic hypertension means the lady already had hypertension. Another thing is gestational hypertension means blood pressure more than equal to 140 over 90 and more than equal to 20 weeks, like after 20 weeks. So purely because of pregnancy, it is there, gestational hypertension. Third thing is preeclampsia, where there is more than 140 or 90, and there is proteinuria.
Mhm.
And then there is eclampsia, means all this plus seizures, right? And then last is the HELP syndrome, which is that thrombocytopenia and liver and all that. Okay, the question is, a lady comes to me, her blood pressure is 145 over 90, and after she's 26 weeks pregnant, and urine analysis shows absent proteins. What to do next in her? What to do next?
Is it a 24-hour protein collection? Urine protein collection?
Wow, superb. Okay, that's the right answer. So you don't rely on urine analysis protein. A pregnant a lady after 20 weeks coming with new onset hypertension, always repeat, must do 24-hour urine collection for total protein. Okay, 24-hour urine collection has to be done. It's must do. Don't rely on urine analysis. Got it?
Yes. Yeah.
Okay. Okay. Then other hypertensives like antihypertensive drugs for comorbid conditions. So not everywhere, like those four that we talked about, they are classic for hypertension. But what if a patient has gout? Then which medication would you prefer? Which anti patient has hypertension but plus has gout? So which antihypertensive would you give? You know that diuretics cannot be given in gout patient, right?
Yes. Calcium channel block.
Okay. Calcium channel blockers can be given, but there is one most preferred one, that is losartan, which is an ARB. Okay, mark it up. That for gout, diuretics are not given. Replace it with ARBs, losartan. Then what if the patient has osteoporosis? Which is the preferred antihypertensive?
Thiazide, diuretic,
Very good. Why? Because it causes
increase
increases
calcium.
calcium. Hmm. Very good. That is there. Yeah. So these two were only the main ones. Okay. And last from this category is not from this category, but cardiovascular complications. This is also high yield, like lot of questions. Cardiovascular contraindications to pregnancy. Okay, cardiovascular contra, which ladies cannot get pregnant if they have certain cardiovascular problem. So, what are the problems that you can think of that would increase the risk in pregnancy?
Low ejection fraction. I don't
Very good.
remember.
Very good. Left ventricular ejection fraction less than 30%. They should not get pregnant. Then,
Like aortic stenosis, like
superb. Symptomatic aortic stenosis. Then, Symptomatic mitral stenosis. Okay.
Oh.
Another very important, I've seen question on this. Another very important is pulmonary artery hypertension. If the patient has pulmonary artery hypertension, she should not be advised to get pregnant. So for them, the answer would be termination of pregnancy. If the patient has mitral stenosis, termination of pregnancy. Or if the patient is coming to you that I'm thinking to get pregnant, should I undergo the repair first or should I do that after surgery? The answer should be first valve repair, then pregnancy. Okay, and if they are already pregnant, then your recommendation is to terminate the pregnancy. And the last is bicuspid aortic valve. Bicuspid aortic valve with aortic regurgitation, ascending aorta enlargement more than 50 mm, because that is causing aortic regurgitation. So three valvular condition: aortic stenosis, mitral stenosis, and indirectly aortic regurgitation. And pulmonary artery hypertension is high yield, left ventricular ejection fraction less than 30%. Got it?
Yes.
Yes.
Okay. So all these are the causes and situations when the patient has hypertension as the first line thing. But what if you gave the medication, it did not work? Then you have to think of secondary causes of hypertension, right? Some
Mm,
other problem in the body that is causing this hypertension. The most common cause, secondary cause of hypertension is renovascular.
mm.
And there is a list of like a few, 6 7 things which are the features suggesting that the cause is renovascular. Anybody knows that list? It's high yield in renal also. What are the few things that would indicate that this hypertension is because of the RAS or the kidneys?
Abdominal brute.
Very good. Abdominal brew. Then
Like serum creatinine will increase more than 30% after starting AC inhibitors.
very good. Serum create more than equal to 30% after starting ACE inhibitor. Okay. Then
Mm, like severe hypertension, like after 50 years.
very good. Blood pressure more than 180, 180, 120 after age of 50. New onset hypertension after age 50.
Mm-mm-mm.
You have given multiple rounds of medications, one, two, three, four. Nothing is helping. So, how should I write? Anyway, so I
Is it uncontrolled?
uncontrolled, yeah, uncontrolled hypertension on multiple medical hypertension. Thank you. Then flash pulmonary edema. Okay. Then patient has any current ongoing atherosclerotic situation.
Mm-hmm.
Can you guys see the screen?
Yes.
Yes. But the list
Isn't
is
it?
gone.
Yeah, even it's blank for me too. Okay. All right. So one is diffuse atherosclerosis, PAD or anything like that. And what else? Yeah, that's it. That's it. Abdominal bruit, asymmetric kidney size, one and the same. Can one of you quickly just repeat these 5 6 points till I repair my screen?
So, severe hypertension after or new onset hypertension after 50 years.
Hmm.
Serum creatinine more than 30% after starting AC inhibitors. Uh,
Hmm.
uncontrolled hypertension for more than three within more than three drugs.
Hmm.
Yes. Recurrent pulmonary edema, flash pulmonary edema,
Very good.
uh, abdominal bruit,
Okay.
mm, and atherosclerosis.
Very good. Atherosclerosis. Okay. Yeah, that's it, right? Is she missing anything? No, no.
No. No. She got everything.
Okay. Okay, great. Uh, my screen is just not letting me work right now. It seems it's just crashing. I don't know why. Maybe it's too much CVS for it. Anyway, so major topic one, shock is remaining. Okay. All right. All right. So let's do an aneurysm. Okay. Aneurysm is also very high yield. Now there are two types of aneurysms. One is thoracic aortic aneurysm and other is abdominal aortic. Now thoracic is little bit easier one. Thoracic aortic aneurysm. There are two types. We can divide it into two types: the ascending and the descending. All right. So what are the causes of ascending aortic aneurysm? Any guesses?
Like in Marfan, Ehlers-Danlos,
Marfan.
Very
yes.
good. Very good. So
Connective tissue
connective tissue
disorder.
disease, Marfan's
Yes.
or Ehlers-Danlos, and one more, which is the major one because normal population will not have connective tissue disease, right? Most common thing would be what?
Hypertension.
Hypertension.
No. Other than that,
Syphilis. Aortic disease.
no,
No.
no. Something common. Something common.
Trauma.
No. But yeah, good. Like you guys are thinking well.
Like aortic regurgitation.
No. Common cause. Most common cause is aging.
Mm.
Okay. Elderly population, aging, because this is a UL question also. What is the most, this patient had ascending aortic aneurysm, somewhere mentioned in the question. What is the most common cause or what is the pathophysiology of this, this situation? And the answer was degenerative aortic disease. Degenerative aortic disease means seen in aging, cystic medial degeneration.
Mm.
Yeah,
Yes.
aging causes cystic medial degeneration. All right. So these are the two important causes for ascending aortic aneurysm, which comprise of 60% of cases, and descending, which comprise of 40%. So for descending, the causes are the other things that you mentioned, that hypertension,
Hypertension.
atherosclerosis because of hypertension, hypercholesterolemia, smoking, all those things. Okay. So hypertension for the latter part, but starting, aging, and connective tissue. Got it, everybody?
Yes.
All right.
Yes.
Yeah.
How is the chest X representation of this patient?
Widened mediastinum.
Super. Widen mediastinum, increase aortic knob, tracheal deviation. If it is very huge, it can deviate the trachea, right? And yeah, what would be that? These are the few things that you will see on the X-ray. What is the confirmatory diagnostic test for thoracic aortic aneurysm?
TTNG.
ETN.
Thoracic.
Echocardiography.
Yeah.
Thoracic. Uh,
Transesophageal.
TTE.
mm, 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 mm.
TTE.
Just
ET angio.
yeah, just do CT, not CT angio also. Just do CT scan. Confirm with CT with contrast. Okay. For the things that you guys are saying, no, they are for aortic dissection,
Mm.
transesophageal echo, CT, NGO. They are for aortic dissection. Okay. For this one,
Yeah.
normal CT with contrast is enough. All right.
Hmm.
Okay.
All right.
Yeah.
Then we have abdominal aortic aneurysm, which is very again high yield. So, what are the common risk factors that you know for abdominal aortic aneurysm?
Smoking. Okay.
Okay, smoking, high yield. Then
Old age.
very good. Older age. Again, super high yield. Old age and smoking. Of course, there is a family history, atherosclerosis, and blah blah blah. But these two are high yield. Now, another important thing about smoking for abdominal aortic aneurysm is this: that if a patient has smoked even a single puff or a single cigarette in their entire life, then
Mm.
also they are at risk for abdominal aortic aneurysm. Okay. Even a single cigarette, risk for abdominal aortic aneurysm. So a lot of questions are around this thing. I told you in exam also there are a lot of questions on screening. So this is one type of question they ask. I've seen such questions in prostate cancer also, and here also, that a 65-year-old man is coming to you and saying that recently my friend got diagnosed with abdominal aortic aneurysm. Even I want to get tested. Should I get tested or not? Then in the question it is mentioned that yeah, I used to I smoked once when I was a teen, and then I've never smoked in my entire life. Should I undergo evaluation or not? And your answer should be
Yes.
yes, right? Even a single cigarette, the answer has to be abdominal USG, right? Not at all harmful. So always answer for screening should be USG. So that is important. All right. Now, if a patient has, this chart is also very high. If a patient has signs and symptoms, okay, and the patient has unstable abdominal aortic aneurysm, then next thing you have to check is whether the patient is hemodynamically stable or not. The signs and symptoms of abdominal aortic aneurysm can be a pulsatile mass, flank pain or groin pain, flank ecchymosis, anything. That is all signs and symptoms of abdominal aortic aneurysm. Back pain, profound hypotension. I mean, that would be still indicating of rupture. Sorry. So these things for signs and symptoms. Next thing you want to check whether the patient is stable or not. Okay. So if the patient is stable, patient is hemodynamically stable, then what next test, diagnostic test, this is the chart for diagnosis, test would you do?
CT.
Very good, abdominal CT. Now if that CT confirms of a this aneurysm, then you will go for medical optimization and repair, and if no, then you have to explore other options, right? But main thing is CT abdomen if the patient is hemodynamically stable and has AAA signs and symptoms. Here is the trick part. What if the patient is hemodynamically unstable? Then what next would you do?
Ultrasound.
We will check if he's a known case of abdominal aortic aneurysm.
Okay, so what if I tell you, I give you two options. The patient has this and is a known case of AAA. Now you have two options, focused abdominal USG or emergency repair.
Emergency repair.
Emergency repair if he's a known case.
Very good. So main thing is the known case. Super. That is high yield. If the patient is a known case, then you directly go for emergency repair. But if the patient is not a known case, you don't know whether the patient is already like you do not know that the patient has AA or not. Then the first thing would be to go for fast, right? You might get tempted if you don't know this step. You might get tempted to check that okay, patient not stable, back pain and everything. So you know from the theory point of view, yeah, that the patient has this aortic dissection, and you will directly go for emergency repair as the answer. But that would be wrong because you don't know the aorta is so long. So you don't know where it is, where the dissection is. So you are not going to cut open the patient from chest to abdomen, right? So the first thing you have to do is localize the situation where the dissection is, where the rupture is. That is why for unknown cases, you have to first go for fast. If that fast also confirms AAA, then emergency repair. Clear, everybody?
Yes.
So this is a trick question they keep on asking. Patient unstable, known case or not, that would be given in the question. Known, emergency, not known, fast.
Yes.
All right. Okay. After this, now there is this PAD and DVT and everything. So that's a completely new section. Let me just quickly check. Actually, we are, yeah, we just have 20 pages. So definitely we'll get done. We did 50 pages in 2 days. So yeah, we have syncope, shock, and then some faltu topics here and there. Main is syncope, shock, and little bit of hypertension and this PAD and everything. Oh yeah, tomorrow I think we'll definitely get done. And if we have time, we can start with something else also. I think we might have some time. Yeah. Alive. Breathing section. And can you believe it? I got it wrong in the real exam. I did it wrong because it was last. I checked quickly and it was wrong. Anyways, you guys remember this? There is a CT scan photograph where this aorta is given and then this tear is given like this.
Mm-hmm.
It's there in the U world also. This picture was given in my exam. This direct photograph, very easy, classic aortic dissection photograph, and just the management was asked. Easy question. But the options which I got confused. Okay, we'll do it when we do the treatment. So, starting with what are the risk factors? Quickly, tell.
Hypertension.
Superb. Then
Morphine.
Marfan's. Okay.
Cocaine.
Very good. Cocaine. Super. So hypertension, cocaine, Marfan's. Okay. Classic presentation. Okay.
Tearing chest pain, radiate to the back.
Very good. Very good. Then anything else?
Mm,
Difference in blood pressure between two arms.
yes.
Superb. Yes. So tearing chest pain, radiating to back, and difference of more than 20 mmHg between two arms.
Mm-hmm.
Okay, just a quick question. So two people are speaking. I assume it's Varda and Janan.
No. Warda.
Mayada is speaking? Okay.
Yes.
Then Janan. Okay, yeah, Janan is not there. Janan, are you there?
I'm here.
You are here? Okay.
Yes.
So I would like your input as well. Okay?
Okay.
I just want to check that you're not sleeping.
Okay.
Okay.
Sleep.
No, just kidding, just kidding. All right. So these two things, high yield. Now other thing which is high yield is the management. Yeah, management. Tell me, what do you think? What is the first diagnostic test? A patient coming to you with tearing chest pain, radiating to the back, you know it's aortic dissection, but you have to diagnose it.
Transesophageal echo.
Transit.
Very good. First line always is transesophageal echo. Transesophageal echo. Now, what if the patient has chronic kidney disease? Oh, no, no, no. Yeah, CKD. Any renal problems? Then,
Chest X-ray.
no. Then too, you can do transesophageal echo, no?
Fine.
Okay. That's the trick part. You still can do TE. That is why TE is most preferred. You don't have to check for anything. Most convenient. So first line is TE. But if TE is not given in the option and the patient does not have any renal problems, then what is the next choice?
CT.
Very good. CT angiography. Okay. A lot of MCQs has this also as the answer. But again, in the options, TE won't be there. So CT angiography. All right. Then what else? Okay, now that you have established that it is aortic dissection, what is the management?
Beta blocker.
Okay, beta blocker, but they are in like this excruciating pain. Would you give anything for that?
Morphine.
Very good. Morphine. Then you said beta blocker. Perfect. So my whole question was, how is this beta blocker given? Oral, IV, IM. Then of course there was calcium channel blocker in the option. There was
IV.
yes. So yeah, the answer was IV. And I got so confused in the last that 1 minute whether I want to go for oral IV or I think I switched it so many times. And then sadly I went for oral and it was wrong. I think I should have just used that little common sense that if the patient is in such emergency situation, they are not going to take oral tablets.
Yes.
Yeah, it was just an easy thing. So IV beta blocker was the answer. Okay. Now, third line, like you, if you have beta blocker and if you have nitrates, both in the option, what would you go for? Nitrates
Beta.
are also vasodilators, right? So why are you not going for vasodilator clearly?
Maybe it would cause hemodynamic instability.
Okay, very good. So, long shot, but it works something like this way that if you give vasodilator, what they will do directly, they will cause this reflex. Not reflex, but vasodilation. So the vagal center is going to get stimulated, right? Because now blood will not reach all the organs. So the vagal stimulation will happen, and the vagus will stimulate the sympathetic, which in turn increasing the heart rate. So it further damages the aortic dissection more. Did I over explain it? Did you guys get it?
No.
Yes.
Okay. Okay, but okay, let me explain again. So,
Yes.
if you give vasodilator, right, what will that do? It will cause dilation in the entire body, vasodilation in the entire body. Now, you know that if there is complete vasodilation in the body, the baroreceptors are going to get activated. When there is extreme vasoconstriction in the body, at that time also baroreceptors get activated. They activate the parasympathetic. But if there is extreme vasodilation in the body, the baroreceptor gets activated. They think that okay, there is vasodilation, so the organs won't get supply. So that will trigger, these baroreceptors are going to go back to the heart, and they will increase the sympathetic activity of the heart, and that will increase the heart rate, increase the cardiac contractility. Now if this contractility is going to increase, then it is going to increase the pressure in the aorta, and that will further dissect the aorta more.
Mm,
Getting it?
yes.
Yes.
Right? So that is why you don't prefer vasodilator in aortic dissection. You never go for this as a first option. If the beta blocker also fails, then you can think of vasodilator in a very controlled manner, little dose you can try. But again, that's not the first line management, never preferred over beta blockers. Got it? So if they give vasodilators and if you don't know this mechanism, then you might get tempted at that time. Clear, right?
Yes.
Yes.
So morphine and IV beta blocker. So that is aortic dissection.